Okay, so welcome to our presentation, Xerostomia, Recognizing and Treating Dry Mouth to Improve Patient Outcomes. I'm Dr. Rowling. I'm the Chief Education Officer here. I'm also a public health dentist in the Phoenix area. Hence, you're going to see some photos of the desert this evening. Now, I've been presenting this course since about 2014. So I'm going to bring in some of my own clinical experience as I speak to you this evening. But again, if you have any questions or comments, those of you who are here watching this live presentation on October 4th, go ahead and type them into the chat area. For those of you that are watching the recording later, you can always reach out to me through the website. So our educational objectives are in your handout there. Understand and define xerostomia. Be able to describe the oral anatomy and physiology related to salivary function and the role of saliva in the oral cavity. We'll discuss composition, etiology, and epidemiology of saliva, how we arrive at a xerostomia diagnosis, recognize at-risk populations, develop and prescribe short-term and long-term treatment options, and describe alternative non-pharmaceutical treatments. And again, Megan will be following up after me, and she'll be talking about one such non-pharmaceutical treatment, the perioprotect tray therapy. So for those of you not familiar with the desert, that is a saguaro cactus. That's something that Arizona is very famous for. That is literally what my backyard looks like. This summer we had, over 60 straight days of temperatures above 115. And unfortunately, these cacti, the saguaro, and they're ancient, many of them didn't even survive this summer. That's how hot it was. They just keeled over. So why do we need to care about xerostomia? Understanding xerostomia and its complications is essential in the proper diagnosis and treatment plan formulation for our patients. And when we look at this photo, some of the things that stand out here, first of all, the tongue, it's cracked, it's fissured, it's angry looking. The dentition, we see the incisal edges have developed decay. We also see root caries, multiple root tips, lack of saliva pooling in the floor of the mouth, dried lips, and so forth. And one important reason that we need to care about xerostomia is digestion, because digestion is initiated in the oral cavity, and digestion requires saliva for both mechanical digestion as well as chemical digestion. In the case of mechanical digestion, we require adequate salivary flow and composition to be able to form a bolus that we can swallow. And chemical digestion requires a healthy composition of the components in the saliva, enzymes, and so forth that initiate the digestion of protein, fats, and carbohydrates, for example. And when we see this patient, this is an older adult, of course. He looks very happy. His smile looks great. He's able to chew an apple, so fruits and vegetables, whole fruits and vegetables, very important. But as you may have seen if you took the course that I presented last night on nutrition, far too often our patients fall into this category, and I call it the Jell-O category or the tapioca pudding category. Their inability to initiate digestion through possibly tooth loss due to xerostomia, or they may have had a stroke, etc. Ongoing infection can lead to their malnourishment and further tooth loss and other comorbidities that include dementia risk, fall risk, isolation and depression, frailty. We know, of course, dental caries and catastrophic tooth loss, and untreated dental disease in this population of institutionalized adults. So older adults that are living in nursing homes, various levels of nursing homes or group homes and so forth. When their dental disease is not treated, that is linked to 1 in 10 deaths due to aspiration pneumonia. So it's important that we identify xerostomia, because if we can identify xerostomia and identify these patients that are at risk before they become the jello line patients, we can help really improve the quality of life and their longevity. And understand for this population that the socialization is very important, and quite a bit of that socialization evolves around meal times. So that's why I have this photo here. Now, in the latter, my latter clinical years, I oversaw a very large mobile program to treat older adults who were living at home, or they were in various nursing homes and so forth. And meal times were important. The medical staff will use meal times to gauge the mental health and wellness of their patients. If the patient's isolating, if they're in their room because they're not able to chew their food or swallow their food, that's a red flag. And that's oftentimes when we get called and when the physician gets called. So identifying at-risk populations and understanding the importance of treating xerostomia and its link to nutrition, morbidity, mortality, we may save a life, or at the very least improve the quality of the life of these patients. So we must acknowledge and identify these at-risk populations, again, and the importance of treating xerostomia and its importance to overall health and well-being. We're much more than just tooth doctors for this patient population. This patient population deserves our best. And oftentimes their complaints are swept under the rug. And understand that for those of you that may see an older adult and the oral hygiene may be horrendous, what you're seeing often is a snapshot in time. Okay, you're seeing patients that have spent thousands and thousands of dollars on their dental care over their lifetime. They may have had insurance as they were employed, and they hit a bump in the road. You know, they hit a medical situation, a condition that may land them in a rehab center and so forth. So we have to give them some grace and understand that they need our attention, our full attention, and our devotion to their care. Okay, so why should we care? Frailty, the association between oral health and frailty here is one of the links for you. And frailty is a slippery slope. Frailty is a situation here that once the patient declines, it's very, very difficult to reverse this situation. And oral health is so associated to these patients' outcomes. And even though they are frail and they're bedbound, we've provided care for these patients with mobile equipment and so forth. Okay. In children, xerostomia, increased risk of dental caries linked to secondhand tobacco smoke exposure. And this is another citation for you. This was a study in Kobe City, Japan, where I believe they looked at 10 years of hospital notes for children up to age 4, I believe. And this is something we go into much more detail in our tobacco course. But these children, when subjected to secondhand smoke, developed a form of xerostomia. And that xerostomia caused an increase level of dental caries. It affected agglutination and so forth. And what it did was it altered an enzyme, a protein in the saliva. So diagnosing xerostomia can be a window to the patient's overall health and well-being. And if you look at this photo, what are some of the things that stand out on the left-hand side versus the right-hand side? The right-hand side, we see a pink, happy tongue. It's papillated. It appears to be moist. The lip appears to be relatively moist compared to the left-hand side. On the left-hand side, we see a tongue that is notably depapulated, it's cracked, it's fissured, it's red, it's angry, it's sore looking. Lips are red and inflamed, and angular cheilitis. Now, last year, a year ago, I had a Clostridium difficile infection that lasted several months, recurrent infections, multiple rounds of antibiotics that didn't work, a diet that was really restricted because I had developed colitis, and I became fairly malnourished. And between the medications and the malnourishment, I developed a pretty severe case of xerostomia, to the point where it was difficult to eat or swallow. It was painful. And I recognized what it was, of course, but I could see the train rolling down the tracks, and it was difficult to pull out of it until the C. difficile was treated and the colitis was addressed and so forth, and my nourishment could improve. But for a while, I definitely looked very close to that photo that you see on the left. It was pretty terrifying. Now, this is a photo of a patient with diabetes and poor blood glucose control, and they've developed pseudomembranous candidiasis. And the signs and symptoms of xerostomia are often associated with or result from other chronic diseases and conditions. And if you took a Q-tip swab, or a cotton tip swab, and you swiped at one of those plaques, you would see an ulceration below that plaque, the pseudomembranous candidiasis. If you look at the tongue here, you can also see that the tongue is coated. And this photo is really very reminiscent also of the AIDS patients that we treated in the early 90s, well, early to mid 90s as well. So sometimes with xerostomia, we have a disruption of the oral microbiome, and it creates sort of a niche where this candida can overtake and infect the patient. Certainly the most famous, one of the most famous conditions here is Sjogren's syndrome, and it's a triad. And we know that also the lacrimal glands can be compromised, as well as the salivary glands. And if we look at this photo, we see a tongue that is also depapulated. It's angry, cracked, fissured, dried lips, and certainly very reminiscent of what you would see in the Sjogren's patient. Now, when we define xerostomia, we're really defining the subjective sensation of oral dryness that the patient describes to us. Okay, it may or may not be associated with hyposalivary gland flow or dysfunction, right? It could be a change in the composition, but again, it's a subjective sensation of oral dryness. It's what our patients are telling us. When your patient tells you that their mouth feels dry at certain times of the day, maybe in the middle of the night, and we examine the patient and they look fine, and we say, well, let's keep an eye on this, we should really take the patient's concerns to heart here. We'll talk about that because they're describing, again, what could potentially be xerostomia that could lead to catastrophic tooth loss. Okay. So the American Dental Association also concurs with that definition, that xerostomia is a subjective sensation of dry mouth. It's a frequent complaint and the most common symptom of salivary gland hypofunction. And xerostomia can be a quality issue versus a quantity issue, or both. Oftentimes you've seen these patients, the stringy, ropey saliva or foamy saliva. And although xerostomia is often a term used for the symptom of oral dryness, it can also be a symptom of a change in salivary composition. So the patient may report to you that they have dry mouth, but what you see is something like this. So the composition has been altered. It could be because of medications, etc. So xerostomia is not a disease. It's a condition. It's a symptom often of a disease or multiple diseases or other conditions, and it can produce serious negative effects. It can affect nutritional status, as I described earlier. It can alter dietary habits, as I described earlier. Most definitely can alter speech, taste, dental prosthetic tolerance, increased risk for rampant dental caries. This is a patient, and these photos that I'm showing you today are actual photos that we had in our programs here that are on the public website for National Public Radio. I was interviewed a couple years back as we were providing care through a mobile program. And this was a patient who entered a residential care facility in the West Valley of Phoenix with all of their dentition intact. And this is how they looked about 2 years later. And most of it was from xerostomia. It was just not recognized. It was not treated. And we would get a call that we needed to come out right away because the patient fractured an anterior tooth. And this is what we would see. So oftentimes these cases were catastrophic. They were often full mouth extraction indentures that the patient was never going to be wearing or able to wear. All right, prevalence. Xerostomia affects 25% of the population, is becoming one of the fastest growing oral health problems in North America. And it's becoming increasingly common in developed countries. Why? Because we live longer and we may have better access to healthcare as well as medications, polypharmacy. Medications are the cause of more than 90% of these xerostomia cases. Estimated over 500 medications can contribute. And there are synergistic effects with multiple medications that can lead to xerostomia, particularly in our older adults. And again, now being recognized as polypharmacy. And 32 million Americans today take 3 or more medications daily. I was in a hospital a few weeks ago to have tests done, and the woman next to me, we were sharing a room for these tests in recovery or whatever. And this particular woman, who was just a year older than me, was on 30 different medications. 30. And I listened to this because I was in there. I had no choice. And everything from diabetes to COPD to you name it. And it was unbelievable. And she was in there for an infection that they were having a hard time controlling. She actually got stung by a scorpion. Anyways, many of you have seen these patients. And when they're on multiple medications, that should be a red alarm for us. We should be digging a little deeper to find out how their salivary flow is, if they're even recognizing they have xerostomia, or do we need to put them on some sort of preventive program? Because by the time we see root tips, now we've entered it's almost too late stage, right? Now, we could start by reducing the synergistic effects of drugs. Perhaps replace one or more of the drugs less likely to cause xerostomia. That sounds very practical, very sound, but is it really? If you're a patient on 30 different medications for COPD, hypertension, AFib, mental health, antidepressants, and so forth, you're going to be hard-pressed to have their primary care physician or their psychiatrist say, yeah, you know what? You're right, this patient doesn't have enough saliva. So let's start flipping some of these medications around. Let's see if we can find something that's going to be less xerostomic. If their patient is stabilized, the answer here is they're going to turn it over to us to try to manage the dry mouth portion of it and help reduce the catastrophic consequences, right? If you have a psych patient with schizophrenia and they're gainfully employed and they've developed xerostomia and some decay, that psychiatrist is probably less likely to start switching around that patient's medications. And again, we're going to be left with helping the patient manage that oral health situation. So xerostomia, not a great problem in the past because people did not take as many medications as they do today. And we said that the most prevalent cause of xerostomia here is polypharmacy. Xerogenic drugs can be found in 42 drug categories and 56 subcategories. And looking at these, you'd be hard pressed to have a patient walk in your door during the day that wasn't on at least one of these. And of course, particular times of the year where allergies may be problematic for our patients, they may develop sort of a transient xerostomia as well. And once the allergies are under control or allergy season is over, they're fine for a few months. So for some patients, these drugs aren't permanent and therefore the effects aren't permanent. But if the patient is on the medication for their lifetime, of course, they may have xerostomia their entire life. For some patients, the xerostomia actually can resolve or improve the longer they're on the medications as well. So patients complaining of xerostomia should be interviewed and their medication should be carefully reviewed. I always ask my patients, do you have enough saliva? Sometimes they're going to laugh because they've never been asked that before. Sometimes they don't recognize that they don't have enough saliva. They're using cough drops because they feel they're coming down with a cold or a tickly throat. And what they're really experiencing is xerostomia. So you'll ask these patients about their medication, and you've experienced this, right? The patients very carefully write down all of their medications. It's almost like the Unabomber's manifesto, right? You're going through all of these. Well, by the time you hit number 3, for the most part, ding, 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 we should just put them on a preventive course for xerostomia because no harm, no foul. They could develop a situation while they're not seeing us, or they could be moved between different levels of care if they're older adults. So it's good to be preventive and proactive. So treatment of drug-induced xerostomia, again, it might be possible to change the medications or the dosage to provide increased salivary flow. Sometimes if the medication's peak plasma level hits in the middle of the night, we may have the doctor, primary care physician may change it so that it hits peak during the day. But understand that xerostomia is often worse between meals at night and in the morning. And we don't want to advise these patients, I'm talking about older adults that are under physician's care, to start sipping water at night without having a conversation with their medical team, because sometimes they're a fall risk. So, or they may be on fluid restriction. They may have congestive heart failure or other things. So we do want to make sure that we're not practicing in a silo, but that we have a conversation with the medical team, let them know the concerns of the dry mouth and what we've seen, and certainly work with the physician to come up with a treatment plan that may be beneficial to the patient. You're always going to want to ask the patient what they're doing when they have dry mouth. How are they treating it on their own? You may find out that they're sipping on lemon juice at 2 in the morning, or they're using Hall's mentholatum cough drops or Ricola, and you retract that buccal cheek area and you see this buccal decay from where they've been holding the cough drop for months and months. So we always want to ask them how they're self-treating so that we can make any corrections and suggestions. Remedy for nocturnal xerostomia, again, we can consider perhaps modifying the drug schedule to achieve maximum plasma levels while the patient is awake in the event that they may be a fall risk, or they're on fluid restriction and so forth. Further considerations on drug management, using easy to take formulations, liquids, for instance. Avoid sublingual dosage forms. If you don't have enough saliva, it's very difficult to dissolve a sublingual tablet. Counsel your patients regarding what medications can and cannot be crushed. Lubricate their mouth and throat with water prior to taking capsules and tablets, and follow this with a full glass of water. And again, we spoke about consider switching medications that may be less anticholinergic, but that is, again, a discussion we should have with the primary care physician. Okay, oral anatomy and physiology related to salivary function, as well as the role of saliva in the oral cavity. And oral glandular tissue embryologic development here begins at about 6 weeks gestation and is completed by about the 12th week, and just that glandular tissue just continues to grow and enlarge until birth. Saliva, defined as the viscous, clear, watery fluid secreted from the parotid, submaxillary, sublingual, and smaller mucous glands of the mouth. I always say it's something we take for granted until we don't have enough, and then it can be pretty miserable. So saliva contains two types of secretion, serous secretion as well as mucus. Serous contains the digestive enzymes. One is ptyalin, and we'll talk about the others. Lipase is another one that initiates the digestion of fats or lipids. And then mucus secretion. The mucus secretion contains lubricating aid. It's a protein, mucins. Again, we're going to break down for you the components that help initiate digestion. In the oral cavity, one is ptyalin, which is an amylase. Another one is lipase, which breaks down fats. So mucins are a family of large, heavily glycosylated proteins. They're secreted on the mucosa via the saliva to maintain the integrity of the mucous membranes. Now, the pH of saliva falls between 6 and 7.4. Saliva also contains buffers, potassium and bicarbonate ions, as well as sodium and chloride ions, and it contains several antimicrobial components: thiocyanate, lysozyme, immunoglobulins, lactoferrin, and transferrin. And purpose and function here: moisturizing, cleansing, lubricating, digestion, remineralization of the dentition, mucosal integrity, immunity, mediator, antimicrobial. It stimulates the minor salivary glands. If the major glands stop producing saliva, it may cause the minor salivary glands to shut down as well. Cellular maintenance, swallowing, taste, and speech articulation. And salivary glands are classified according, again, to the type of secretion, whether they are a major or minor gland, and their innervation, parasympathetic versus sympathetic innervation. So when we classify salivary glands by secretion, they're classified as serous, mucus, or mixed. So serous secretion is the very thin and watery secretion secreted by the parotid and the lingual glands. And the mucus secretion is that very thick, viscous secretion secreted by the palatine, posterior lingual, and buccal glands, and then a mixed of both, so mixture of the two, secreted often by the sublingual, submandibular, anterior lingual glands. Also classified by major or minor glands. So the major glands secrete intermittently. They secrete on cue. You smell garlic in a pizza restaurant, you may salivate. Minor glands secrete continuously, and they're protective, right? Their role is to maintain the integrity and the moistness of the mucosa. So the parotid gland is the largest of the three major glands. It produces 30% of the total saliva output. Of course, Stenson's duct is the parotid duct, and innervated by sympathetic and parasympathetic divisions, and it secretes a serous type saliva. The submandibular gland is the second largest salivary gland and produces 65 to 70% of the total salivary output. The duct is called Wharton's duct, and the Wharton's duct exits on the floor of the mouth, opposing the lingual surface of the tongue, and innervated by parasympathetic nerve endings and possesses no sympathetic receptors. And the parasympathetic fibers arrive through the facial and glossopharyngeal nerves, and it's a mixed secretion, but mostly on the thin side, the serous side. Sublingual gland, smallest of the major glands, produces less than 5% of the total salivary output. We all remember ducts of Bartholin. That's a board question. Innervated by parasympathetic fibers, little to no sympathetic influence. And it is also a mixed secretion, but primarily mucus on the mucus side. Minor salivary glands are found throughout the mouth. So the lips, the buccal mucosa, the alveolar mucosa, the dorsal and ventral aspects of the tongue and the floor of the mouth, they secrete continuously, as we said, protective of the mucosa. And if you've ever accidentally bit your lip, or you've had a patient that has had a mucocele, sometimes what you're seeing is an obstructed minor gland. So the mucus is backed up. Okay, and then salivary gland classification by innervation. So sympathetic versus parasympathetic. The sympathetic is the dry, thick, ropey saliva is responsible for that. And the parasympathetic innervation is responsible for the thin, profuse secretion. And the sympathetic and parasympathetic work in opposition, and they can influence the quantity and the quality of saliva. We're going to talk now about etiology and epidemiology of xerostomia. Salivary flow, the normal daily production varies somewhere between 0.5 and 1.5 liters. Whole unstimulated salivary flow rate is thought to be 0.3 to 0.4 mils per minute. And this rate decreases to 0.1 mils per minute during sleep because the parotid gland shuts down. Unstimulated flow, resting salivary flow, no external stimulus, less than 0.7 mils per minute is considered hyposalivation for stimulated flow. And the normal stimulated salivary flow rate averages 1.5 to 2 mils per minute. So stimulated flow, again, is a response to a stimulus. So taste, chewing, medication, mealtime. And salivary flow facts, salivary flow peaks in the afternoon. It decreases at night again when the parotid gland shuts down. And the composition, 90% is water, 10% inorganic and organic ions and cellular components. We spoke of the cations earlier. Sodium, potassium, and calcium are all the positive ions. And then the anions, the negative ions, chloride, bicarbonate, and phosphates. And it's the cationic and anionic components here that play an important role in salivary function, because as saliva passes through the salivary ducts, the cations are reabsorbed into the adjacent blood vessels, and in exchange, the bicarbonates, potassium, are transferred from the blood vessels into the salivary ducts. We also know that fluoride is secreted in saliva, but unlike the ions in saliva, fluoride content level is not altered whether salivary flow is stimulated or unstimulated. Now, enzymes and organic components of saliva. Amylase, as we said, the ptyalin converts starch into glucose and fructose. We have lysozymes, which are antibacterial or antimicrobial, histatins that prevent fungal infections, so antifungal, antimicrobial, secretory, IgA, an immunity mediator. Lactoperoxidase stimulates the minor salivary glands, as we said. So if lactoperoxidase is not produced in the saliva of the major glands, it can affect salivary flow of the minor salivary glands. RNAs and DNAs for cellular maintenance. Lipase initiates the digestion of fat. A kallikrein is a vasoreactive substance. Stadherin is a protein that inhibits the precipitation of calcium phosphate in the saliva, and it permits the remineralization of enamel and high phosphate levels for buffering. And these are just a few of the enzymes and organic components of saliva. And then cellular composition of saliva, epithelial cells, neutrophils, lymphocytes, and of course, bacterial flora. So the oral microbiome, if you will, which you're hearing more and more about, all important. Okay, Let's talk now about factors that affect salivary flow. Early on in the pandemic, there was quite a bit of research on xerostomia in patients with COVID-19. Dry mouth was reported as a symptom of COVID-19. This was a study where they took a deeper dive, and dry mouth was assessed in hospitalized patients with COVID-19 daily until all of the dry mouth symptoms resolved. And the results here, dry mouth appeared in 60% of the cases 3 to 4 days prior. So they thought to be a prodromal symptom. And in some cases, simultaneously or 1 to 2 days after the onset of symptoms. Conclusion here, xerostomia and COVID-19, they thought could occur before the common symptoms and may be hypothesized as a useful tool for the early diagnosis, quarantine, and treatment. Another case here, also Freni et al. Xerostomia in patients with COVID-19. The researchers demonstrated in most of the cases, xerostomia occurred before other symptoms of the disease, and the severity diminished after 15 days. Of course, we know that xerostomia is associated with autoimmune diseases. Sjogren's is the most common disease to cause xerostomia. As you know, lupus is another. Also associated with other systemic diseases, asthma, sarcoidosis, diabetes, renal failure, HIV. In asthma patients, this was a study where they wanted to understand better the xerostomia as it related to the degree of asthma control. In the study, this particular study, 57 patients were treated with inhaled corticosteroids for bronchial asthma. And they looked at a cross-sectional observational study. They used a xerostomia inventory test in the degree of asthma control according to the asthma control test collected for each patient. 40 patients had asthma, 17 did not. And in the asthmatic group, patients with uncontrolled asthma had worse xerostomia inventory test scores than those with partially or totally controlled asthma. So it was determined that from this study, not a large sample size, but that a moderate relationship between the degree of asthma control and the severity of xerostomia. And of course, your patients that are on bronchial or on inhaled corticosteroids are told to do what after they use it? To rinse with water. But those corticosteroids can really change or alter the oral microbiome as well. And these patients will develop, oral candida and so forth that sort of complicate the situation and cause the xerostomia. Sarcoidosis, this is a disease. It's an inflammation of the lungs, various organs, eye, skin, tissue, lymph nodes. The cause is unknown. They believe it's triggered by dust or chemicals or a bacterial or viral infection and may have a genetic predilection, and xerostomia may be a symptom of that. Of course, diabetes, we spoke about salivary stadherin earlier. The secretion of salivary stadherin in uncontrolled diabetic patients can be compromised. So the stadherin protein in the calcium phosphate precipitation that enables the remineralization of enamel and stabilizing phosphate buffering capabilities in saliva becomes compromised. And so that can lead to increased dental decay in those patients. Kidney disease, renal failure, by default, these patients may be on dialysis, they may be on Lasix or medications that secrete fluids, right? So in that case, if they're on a fluid restriction or dialysis, that can cause a sort of a state of dehydration. Also, whatever condition got them in the situation of renal failure as well, and any medications. So again, diuretics, etc. And then HIV. So salivary gland disease associated with HIV infection can present as xerostomia with or without salivary gland enlargement. And xerostomia is sometimes seen in these individuals. HIV-infected patients may also experience dry mouth in association with certain medications they may be taking. including antidepressants, antihistamines, antivirals, and anxiolytics. Additional factors, psychogenic, so stress, anxiety, depression, and that could be due to neurogenic and medication, radiation therapy. So glandular fibrosis can occur. Sometimes it's not 100%. The gland may still have some tissue that is still able to function and can still produce some saliva. And sometimes the gland may be totally destroyed by radiation. In that case, it's not going to produce any more saliva. Gender predilection, so women and 70% postmenopausal. And this was a study where they looked at women that were menopausal. And in the menopausal group, the salivary flow showed reduction, but without clinical symptoms of dry mouth. So it was important, according to this study, to normalize salivary flow to prevent oral abnormalities and maintain oral health. So it's something to keep in mind if you are treating patients that are perimenopausal, to perhaps consider some sort of preventive regimen. Neurologic here, this is a study about Parkinson's disease and dry mouth, an often overlooked autonomic symptom of Parkinson's disease patients. And we know there's involvement of salivary glands in Parkinson's disease patients. However, the prevalence of dry mouth up until this point had not been systematically assessed in these patients. So studied 97 patients with Parkinson's disease and 86 controls. They used a questionnaire. Dry mouth was reported by 60.8% of the Parkinson's patients and 27.9% of the controls. Dry mouth and drooling coexisted in 30% of the cases. However, only 12% of these patients had reported dry mouth symptoms to their physicians. So it's thought that dry mouth is a frequent but underreported symptom and may be an early manifestation of autonomic involvement in Parkinson's disease patients. Additional factors, circadian rhythms. We may see a decrease of salivary flow in the fall. Age. Studies show that among non-institutionalized older adults not taking medication, neither the quantity or the quality of saliva change significantly with age. You may see that on the quiz. However, we know growing older and wiser means that we may be subjected to other diseases and conditions that require us to take medications or may have some xerostomia causative factors. So again, just growing old doesn't mean that the salivary glands give up the ghost and stop producing saliva. There are other factors involved. Studies show a positive correlation, as we said, between the number of drugs taken and the incidence and severity. Signs and symptoms here. Individuals with xerostomia, they may complain about issues with eating, speaking, swallowing, retaining their dentures. They may not be able to eat dry, crumbly foods like cereals and crackers. It may be particularly difficult for them to chew and swallow. They may not come out and say, I have dry mouth. They may say, I can't chew my food, or my dentures aren't working well for me anymore. Denture wearers may have problems again with denture retention, denture lesions, sores, tongue sticking to the palate. Patients with xerostomia often complain of taste disorders or a painful tongue, glossodynia. They may have an increased need to drink fluids, especially at night. That's why it's a good idea for us to ask them what they are doing for self-care. And xerostomia can, as we know, lead to markedly increased dental decay, parotid gland enlargement, inflammation, fissuring of the lips, inflammation or ulcers of the tongue and buccal mucosa, oral candidiasis, salivary gland dysfunction, halitosis, cracking and fissuring of the oral mucosa. Evidence from the patient's history. We're going to look at what they've divulged in terms of their health history and experience, examination of the oral cavity. Various tests can be performed, as we'll see, to measure the flow rate of saliva or obstruction, perhaps. And xerostomia should be considered if the patient's complaining of dry mouth. particularly at night. Difficulty eating foods, as we said, when the mouth is examined, a tongue depressor or the mouth mirror may stick to the cheek or the tongue. And this one I'm not so sure about, but in women, the lipstick sign where lipstick adheres to the front teeth may be a useful indicator of xerostomia, or it may just be a useful indicator of someone with an overjet, right? All right, diagnosis of xerostomia here. Oral mucosa may be dry and sticky. It may be erythematous. We may see an overgrowth of Candida albicans. We may see red patches that are present on the hard or soft palate. Occasionally, we may see pseudomembranous candidiasis. There may be little to no pooled saliva in the floor of the mouth. The tongue may appear dry, decreased numbers of papillae, and the saliva, again, may be stringy, ropey, or foamy. We may see cervical decay or decay of the incisal edges. There are several office-tested techniques that can be performed to assess the function of salivary glands. Silometry is a salivary flow measurement, so collection devices are used, and saliva is stimulated with citric acid, and the rate is measured. Typically, values less than 0.1 per mils per minute are typically considered xerostomic. And other silography is an imaging technique. So this is looking for salivary gland stones or masses. Salivary scintigraphy and assessing salivary gland function. Again, the rate and density of uptake of the medium that's being used and the time of excretion in the mouth. Minor salivary gland biopsy used in the diagnosis of various diseases. Sjogren's syndrome is one. HIV, salivary gland disease, sarcoidosis, amyloidosis. And then biopsy of the major salivary glands is an option when malignancy is suspected. At-risk populations, patients on multiple medications, are older adults. However, we said age is not necessarily predictive. Doesn't mean the salivary glands are atrophying after the age of 65. Behavioral health patients and special needs patients. Okay, symptoms again, viscous or sticky saliva, difficulty speaking or swallowing, halitosis, altered taste, complaint of dryness, burning mouth, lips, or tongue, altered sense of smell, frothy saliva, gingivitis, absence of saliva, cracking and fissuring of the food sticking to the oral structures. Again, signs we may see increased root caries or incisal caries, food sticking to the teeth and the mucosa, frothy, ropey saliva, gingivitis, absence of saliva, cracking and fissuring of the tongue, ulceration of the oral mucosa, little to no pooling of saliva in the floor of the mouth, recurrent Candida infections, toothbrush, mouth mirror instrument that sticks to the mucosa, and poorly fitting prostheses. So this was a case in Prescott, Arizona. Again, these photos are on National Public Radio here. This was a patient who entered a facility with all of their dentition and an upper partial denture. And this is what they looked like about 2 years later from xerostomia. Develop and prescribe short-term and long-term treatment options for xerostomia. So we certainly have a multitude of over-the-counter products that are available with xylitol out there. And I'm not going to make any endorsement for a particular product over the counter, but I tend to rely on products with xylitol. Advise the use of sugar-free products only. Anything with citric acid, I would eliminate. Fluoride gels, toothpaste, fluoride trays. I'm a fan of fluoride varnish in these various residences that I worked in because sometimes I only have a window of time and there's nobody really there to administer the fluoride trays and so forth. And determine a cause or attempt to reduce the incidence through polypharmacy. So if you are working in a facility, it's really a good idea to be able to educate the staff, the caregivers. If you're working with a patient who's homebound or someone who's independent, it depends. It's a good idea to get a handle on who's helping them, and if we are prescribing some sort of therapy, is there someone there available that's going to help assist them if they need it? And if they don't need it, then great. Okay, management. Again, symptoms should be noted, signs recognized, so that we can properly diagnose the condition. And the goal here, when we can, is to increase salivary flow. So there are drugs that mimic or stimulate the parasympathetic division of the ANS, and this has been useful sometimes in patients with radiation therapy or Sjogren's syndrome. But there are adverse side effects with those medications: sweating, urination, nasal congestion, lacrimation, abdominal pain. Again, sugar-free lozenges, really the sprays early on are better because they may not have enough saliva to allow those lozenges to melt in their mouth, and try to eliminate the citric acid. There are saliva substitutes available as well as over-the-counter for medication-induced or salivary gland hypofunction. Oral hygiene should be scrupulous, at least 4 times daily. They can rinse with baking soda solution 4 to 6 times daily. So an 8-ounce glass of water and a teaspoon of baking soda. Again, avoid citrus juice. Keep water handy as an oral moisturizer if that's okay with the medical team. And of course, management, we're going to avoid sugar in the foods and beverages, alcohol and salty foods. Denture maintenance is a must. So sometimes you have to teach the hospital staff or the caregivers how the care and feeding of a denture. How is a denture cleaned or a partial denture cleaned? Imagine the patients now that have all on fours that are in memory care facilities. Who is taking care of those? I can tell you, probably nobody. Fluoride varnish at prescribed intervals, moisturizers on the lips, salivary substitutes, particularly xylitol, antifungal treatment as required, and reevaluate the denture patients for optimal adaptation, fit, and monitor for denture stomatitis. And in the denture patient, what I want to do is try to optimize the tissue and concurrently apply a temporary reline to a denture that we've cleaned professionally when we can. So I, like good old Co-Comfort, I would apply that each week. I would have the patients using over-the-counter products with xylitol in them. And in some cases, I may have them use nystatin if I believe they have a fungal infection as well. Once we get the tissue optimized and we can take a look at the reline and see, can the patient's denture be refabricated, or are they going, or I'm sorry, relined, or are they going to need new dentures fabricated? And of course, denture stomatitis is a concern in this patient population. So dentures are really meant to bear or rest on moist tissue. So we want to try to get the tissue as close to normalization as possible. And we can buy time by performing these weekly temporary relines and having the patient go through the process of using various over-the-counter rinses, as well as antifungal if they require it. Some patients are predisposed to candidiasis because they lack salivary histatins. Antifungal medications can be used. A molecular iodine rinse, here is a citation, and there's a course on our website by Dr. Moskowitz, who holds the patent for one of the molecular iodine products out there. So if you want to learn more about that, you can go to our website. Treatment recommendations here, again, for oral candidiasis: nystatin rinse 4 times per day. I like them to use nystatin ointment on the corners of their lips and the marionette lines where that can be inflamed. And of course, treat the denture. The denture needs to be cleaned, and the caregivers need to be educated on how to clean a denture. Bacterial infections can be treated sometimes with antibiotics or sometimes just by increasing hydration and salivary stimulation. And then we spoke about poorly fitting prostheses here, dental caries, of course. I'm a fan of fluoride varnish for the older adult population that I've been talking about here. Frequent examinations dysphagia, the difficulty of swallowing, careful eating, smaller bites, copious use of fluids if they're permitted, avoid dry, hard, sticky, and difficult to masticate foods, and foods that don't taste right. Sometimes drinking fluids while eating can help as well. And then we spoke about using oral moisturizers, lubricants, mouthwashes, sprays, sugar-free gums or mints, artificial salivary replacement, prescription medications. Pilocarpine is one, servimilene is another. Lubricants on the lips every 2 hours, and then the use of a bedside humidifier during sleeping hours. There is also evidence that low-level laser therapy or cold laser in a few studies has been used to improve salivary flow. And this is called photobiomodulation. That's the new term for low-level or cold laser. And this is a course, standard level certification is offered now by the Academy of Laser Dentistry. And it's used to treat xerostomia and associated conditions like angular cheilitis and your denture sores. Other benefits include reduced need for local anesthetic, improved and quicker post-operative healing, less post-operative complications such as dry socket, reduced post-operative discomfort, improved osseointegration implant patients, and treatment of TMD. If you want to know more about photobiomodulation, you can drop us a line and we'll send you the link over to the Academy of Laser Dentistry, or just go directly to the Academy of Laser Dentistry and talk to Donna. She runs their CE program and she'll get you set up. This is one of the devices now. You don't need a laser. You can use an LED and just light up those glands, and you will sometimes get more saliva produced. And again, I'm going to show you a couple of the studies here. So photobiomodulation, known as PBM, this is the application of red and near infrared light over injuries or lesions to improve wound and soft tissue healing, reduce inflammation, and give relief for both acute and chronic pain. And we spoke about the benefits. This is actually Dr. Jerry Ross from the Academy of Laser Dentistry, and he's using a device. And you can use this device to cover all of the glands. Here is another study, the benefits here. Different protocols for PBM therapy of hyposalivation. Both laser wavelengths they used here were effective in increasing salivary flow rate. The improvement in salivation was statistically significant. Not only stimulative effect, but also indicating regenerative potential of PBM therapy, and that was after 10 days. This is another study. The results indicated that the effects of low-level laser therapy on salivary glands, not only stimulating, but also regenerative to a degree, since the glandular response to the same amount of applied laser energy increased linearly over time. Here are our resources here. And we do have a course on our website. This is Dr. Grace Sun, who is an expert in photobiomodulation. She will be the president of the Academy of Laser Dentistry next year. And her course is currently available on demand at no charge on our website. It's photobiomodulation and acupuncture and orofacial pain management. And she devotes a section to treating xerostomia. So if you want to see a demonstration of that, this is an excellent course, and it's 1 CE credit, no charge. So we have a couple of questions here. I thought only carbohydrate digestion starts in the mouth by Thailand. Nope. We also have evidence that fats as well as proteins, the digestion is initiated in the oral cavity as well. Any other questions or comments? So if you did not get the handout, please be sure that you have it by going to the chat area. There is the blue box. I am going to bring up the presentation now by Megan from Perio Protect. And she's going to go ahead and log in.
Hi, Dr. Rowling. How are you?
I'm good. How are you, Megan?
I'm doing well. Thank you. I know it getting dark earlier here in the Midwest is absolutely killing me. So I don't know how everybody else feels, but I am missing that long sun
We're
throughout the
still
day.
getting the long sun here in Arizona. To be honest, I'm kind of happy that we have less sun during the day here, because it was 60 days of like walking out onto the surface of the sun. It was unbelievable here.
I can only
So,
imagine.
yeah. So, 85, 90 degrees feels like cool weather to me now, which is kind of crazy.
Yeah.
Um, Everyone, I am going to introduce you now to Megan Radcliffe, who is a registered dental hygienist, and she's worked for 7 years in clinical practice, treating hundreds of patients with the help of perio tray therapy. And her clinical experience fuels her work as a team trainer with Perio Protect. She is most passionate about empowering hygienists to think outside the box by using and understanding the need for adjunctive therapies in and out of the hygiene operatory. Thank you for being here tonight, Megan. And I want to thank everybody who's staying on to learn more about Perio Protect's tray therapy, because it certainly has such a great application to your xerostomia patients and the inflammation that can develop when they are experiencing dry mouth and extra calculus and so forth. I want to also point out to everybody that your presentation is in their course folder, and we're going to go ahead and put the link up to Perio Protect here momentarily. So I'm going to turn it over to you, Megan. Thank you.
Thank you, Doctor. Appreciate it. Thank you also, everyone, for staying on and listening. Dr. Rowling, as you probably already know, I'm sure this isn't your first time listening to her, but she always comes with the latest and greatest. And every single time I listen to her, I learn something new. So even though I don't present until much later on, I always stay on and I listen to the whole thing, because it's always good to pick up little nuggets of knowledge, as you all know. There may be some of you on here who are already utilizing Perio Protect in your practices. I hope that that's the case. And if there are, and if you have questions, please let me know. Again, that's really what this time is for. But we're going to be talking a little bit about Perio Protect tray therapy and how you can utilize it in your practice, and especially how it relates to dry mouth. So just to recap a few things that Dr. Rowling discussed, or the fact that saliva is so beneficial because it's going to help moisten tissue. It kind of works as an antimicrobial. Certainly it's going to help cleanse. Different reasons why we need saliva. It's so super important to our everyday lives. And why, again, how we can understand the symptoms, and again recognize when patients are kind of at risk of developing xerostomia, or patients who already have xerostomia. And as we know that patients, I truly believe, as a hygienist, they are doing what they're supposed to be doing at home. I believe that they are brushing and that they are flossing, and maybe even sometimes they are using their water picks, but they're just not getting down to the base of the pocket and being able to debride that bacteria, especially when there's early colonizers of pockets. And again, we're allowing those bacteria a chance to mutate if they stay down in those pockets too long, and that's when it's eventually going to cause periodontal disease. So it's really important for us to be able to manage that bacteria and that biofilm on a daily basis. And there's about 4 million bacteria roughly just on the end of a ballpoint pen. So putting that into perspective of how much bacteria is truly down in these pockets that we're not even seeing clinically. So I encourage you to change your mindset a little bit about dental hygiene and take it from, okay, it's about the deposit, to really it's about the bacteria. So how can I treat not only the deposit, but also the bacteria to be able to get those optimal results? And the best way that I knew how with my own patients was with the help of the Perio Protect tray. So there are a few points that I want to make, or I would like you to make when you're talking to your patients about Perio Protect. So Perio Protect is actually FDA cleared, and we say cleared, not approved. The FDA does not require Class 2 medical devices to be approved. So a Class 3 medical device, which needs to be approved by the FDA, is something similar to a joint prosthesis or a pacemaker, things of that nature. So again, the fact that we are Class 2 does not require approval of the FDA, but we are cleared by the FDA. The tray is also patented as well. So you are not making these trays in your practice. You are sending them off to a certified Perio Protect lab to be fabricated to that patient's dentition, either off of an intraoral scan and or impression, something similar to that, but also made to the depth of their periodontal pocket. So you do need to send in that most recent probing, usually within 6 months, nothing older than a year. We should be probing much more than that. And again, they're making that tray to the depth of that pocket. So there's an inner peripheral seal along the gingival margin of the ParaProtect tray that's going to push the medicament deep down into the pocket. And what the research shows is that it can be delivered up to 9 millimeters, which, as you know, is super exciting, especially from a hygiene standpoint. So what is it exactly that we are delivering? We have a 1.7% hydrogen peroxide gel. And as you all know, hydrogen peroxide is pretty miraculous for multiple reasons, but specifically at 1.7%, we're targeting anaerobic bacteria. So unlike when patients would rinse with full strength hydrogen peroxide and they run the risk of ruining those good bacteria as well as the bad bacteria, we don't run that risk when we're using low dose hydrogen peroxide at 1.7%. So again, kind of nice there to know that we're not ruining our good bacteria as well. And just as Dr. Rowling said, we need to take time out of our appointments, just 1 or 2 minutes, and help patients to understand that their immune systems are truly like a battery. Therefore, the more chronic, low-grade infections we place on our immune systems, the quicker we're going to see that battery fade. And just as you all know, very rarely, if ever, do patients just come in with periodontal disease. They also come in with type 2 diabetes, rheumatoid arthritis, different types of cancers, cardiovascular diseases. I mean, there's at least 50 comorbidities that are directly linked to periodontal disease. So you need to help your patients to understand that if we can help treat one of these infections, aka periodontal disease, we're essentially going to be able to make our batteries last longer. So again, I encourage you to take time out of your appointment to make this make sense. Use their medical history as a roadmap to explain to them why this is so important. And something that I used to tell patients is plaque in your mouth or bacteria in your mouth is bacteria in your bloodstream, bacteria on your brain, bacteria in your heart. Again, it's all connected. And patients don't often make that connection. They simply think that their mouth is separate from the rest of their bodies. And we know very well that that is untrue. So again, make those connections for your own patients. I do want to briefly go over our in vitro study. This was done in our 1.7% hydrogen peroxide gel. And there's a few points that I want you to take away from this study in particular. So the first one being is that this study was solely done on Streptococcus mutans, which, as you know, is one of the #1 bacteria associated with decay. So again, if we have xerostomia and we don't have the help of the saliva being able to cleanse the teeth and moisten the tissue, then we run the risk of dental caries and decay. So this is a really helpful system to be able to fight that decay or that bacteria that's causing that decay. So again, we did this on Strep mutans because it has one of the thickest matrices to be able to penetrate. So we knew that if we could penetrate Strep mutans, then we're really doing something great. Not only that, but again, we know that it's extremely effective against periodontal pathogens because the majority of them are gram-negative anaerobic. Hydrogen peroxide is going to break down oxygen in water. Therefore, we're going to be able to deliver oxygen to anaerobic environments. So kind of creating more of an oxygen-rich environment, essentially at the expense of bad bacteria. The other part of this is that you will always treat your patients for 10 to 15 minutes. Simple as that, 1 to 2 times a day. Hydrogen peroxide gel, once it's concentrated and it reaches saliva, is going to break down after about 17 minutes. So they're going to lose their antimicrobial properties after that time frame. So just keep it super simple and always tell patients 10 to 15 minutes. So in that very first slide is where we let Strep mutans grow for 3 days. We're like, okay, we're going to let it grow and then we're going to try and treat it. So in the middle slide is where we treated it for just 5 minutes. As you can see, not a whole lot has happened. Only 5 minutes has passed. We're not really expecting miracles at this time. The key is in the very last slide where we treated it for 10 minutes and we were able to kill 100% of surface Strep mutans within that time. So I do encourage you as clinicians, don't just treat your periodontal patients, treat your high caries risk patients as well. We can assume that if we're killing the #1 bacteria associated with decay, patients who are compliantly wearing ParaProtect trays are going to have a much decreased rate of caries over those patients who are not. And I do want to talk about the formulation of the gel very quickly. Again, ParaProtect, for those of you who may not know, has been around since 2005, so for 18 years. And in those 18 years, there have been other brands that have tried to come out and say, oh, we also have a 1.7% hydrogen peroxide gel, and they very well may. But the best part about it is that they're actually using our original hydrogen peroxide study to promote their own gel. So they have none of their own research to provide how safe their gel is, how effective their gel is. So we tested these other gels up against Gel, and this is what you're seeing on the screen. Gel is on the left with all the red dead bacteria, and the other brand is on the right. After the same amount of time, less effective at killing bacteria, also super watery in consistency. And they also had 2 ingredients that released formaldehyde upon use. We here at Paraprotect are not trying to preserve your patients while they're still alive, so you can rest knowing that our gel is not going to produce formaldehyde. So again, it's important to make these notes when you're talking to patients because they need to know that what we have prescribed for them is not only safe, but it's also extremely effective. But talking a little bit more about hydrogen peroxide, again, it's a wonderful broad spectrum antimicrobial, wonderful wound cleaner. We've been using hydrogen peroxide for literally years on wounds. And again, now that we've concentrated into a gel, it's even more effective at disrupting that slimy biofilm matrix that we were just talking about, help debride the bacterial cell wall, deliver oxygen to those anaerobic environments. Hydrogen peroxide is also going to help denature calculus deposits. So if I have any hygienists left in the presentation, this should really excite you. I want you to think of calculus as essentially a protein skeleton. So calculus is made up of protein chains, and what the hydrogen peroxide is going to do is it's going to break the protein chain to make it easier to remove and actually keep it from rebuilding. So again, for your patients who are compliantly wearing this, it should be really, really, really easy to remove, extremely chalky, and should keep it from rebuilding. No allergic reactions. We're making hydrogen peroxide naturally every single day in our lungs, in our liver, and in our white blood cells, which I feel as if maybe that's something that not a lot of patients realize. They think hydrogen peroxide is still kind of taboo. And maybe we're kind of at fault for that because we've told them not to use it for so long. But what we really meant was not to be using it at high concentrations. Again, we don't run the risk of ruining our good bacteria. So we're going to use it at low dose, just 1.7%. And then the very last bullet point is definitely one worth mentioning. And we're going to be talking about this a little more in depth also on the 20th. I hope that you can all make it for Dental C Academy's symposium. It's going to be absolutely wonderful. It was amazing last year. Dr. Rowling is going to be speaking, Dr. Tom Palmer, but it's the fact that bacteria cannot build up resistances to hydrogen peroxide like they do to antibiotics. And this is worth mentioning because dentists are the number 1 prescribers of clindamycin, and clindamycin is the number 1 antibiotic associated with C. diff, which, as we know, is an antibiotic-resistant infection. So we don't want to continue to put these patients at an increased risk by overloading them and overprescribing antibiotics. We should be using something more natural, such as hydrogen peroxide, because, again, they can't build up those same resistances. So if there was a silver lining of all of this, it would be that. We do have 2 perio gels. We have the original perio gel, which is sweetened with saccharin. It's extremely minty. I personally love original gel because that's what I was used to for so long. But we also do have Gel X, which, as you can guess, is sweetened with xylitol, like we talked about earlier. So xylitol is extremely effective against dry mouth patients. It's also been known to help balance pH in the mouth, again, increase salivary flow. So I feel like it's gained a lot of popularity in its 2 years of being out just because of those additional properties. A lot of our newer offices are really loving the xylitol gel. There is no price difference, guys. There's also no shelf life difference. They both have a 24-month shelf life. And you can use that D9630 code to be able to charge out the gel in your practice. And if you guys want to become providers, again, you can contact us. You will go through a 1-hour training, and we'll kind of dive into this a little bit deeper so that you have a full understanding of how long gel lasts. Again, things like that. But I want you to also know that they did conduct a 6-year study on 1.7% hydrogen peroxide, where they followed patients who use it every day, multiple times a day. And again, there was no carcinogenic effects, no adverse events. So again, extremely safe to be used every day by your patients. We're also going to be able to help whiten our patients' teeth, which I think was the first question out of the majority of my own patients' mouths is, hey, I know that I may be having some issues with my gums, but do you think I could whiten my teeth, and how soon? So again, this is going to very gradual lighten their enamel over time, 3 to 6 months into treatment, unlike with carbamide peroxide, which comes at a much higher percentage, usually between 25 and 45%. Again, this is 1.7% hydrogen peroxide. But because the concentration is so low, we don't run the risk of sensitivity like we do with carbamide peroxide. And also, we don't run the risk of clear incisal edges. So if you guys have ever seen that, that can often be from over whitening. And again, we get that with those high dosages of carbamide peroxide. The other cool thing about the tray, and that's what I love about ParaProtect, is the fact that it's so multi-use, is that you can actually help to treat, again, your high caries risk, your xerostomic patients, or your sensitive patients as well with the help of the tray. You can use fluoridated prescription products such as ClinPro, Prevident, and MyPaste, Reminpro, Carry Free. There are so many different products out there on the market now that are available to you. So whether you're recommending them or prescribing them, or maybe you're even selling them in office, know that patients can use this to help treat chronic sensitivity for 3 20-minute applications within a 24-hour period. Or if you're treating a high caries risk patient or a xerostomach patient, it would just be 1 20-minute application one time a week. So again, you have these tools to use within your tool belt. We just need to know how to use them all together. So talking about a few different types of patients that work really well with the help of ParaProtect. Obviously, your preventative patient is really going to be your first place to start. Again, we don't allow disease to progress. So when we notice bleeding and when we notice pocketing, that's really when we should intervene. And again, be using that verbiage. We don't allow bacteria to mature. We don't wait for disease to progress. So be recommending this to your preventative patients with 10 bleeding points or more. I know Dr. Rowling very briefly talked about halitosis. Again, I think it's a great point to make. You should be using this really as a precursor to periodontal disease. And something that a lot of patients as well as clinicians don't realize is the fact that halitosis is caused by gram-negative anaerobic bacteria, some of the same bacteria that's causing periodontal disease. PG being one of them, TF is another, FN is another. And again, these are some of the big key players in perio. So use this as a precursor. Put this on your medical histories too, teams. If you're having a hard time bringing this up to patients without, sounding rude, just say, hey, I saw you mark this on your medical history. How much is this affecting you on a scale from 1 to 10? Is it just in the morning? Does it kind of last all day? And that should kind of give you a gauge, again, on how this is affecting them as a patient in their day-to-day life. The next type of patient is going to be your maintenance patient. So after they've done their scaling and root planing, and now they're in their 4910 or their periodontal maintenance, are they still having bleeding and are they still having pocketing? And a lot of the times, again, it can be because of home care. Maybe we left a deposit behind. But there are also 3 bacteria that are actually resistant to scaling and root planing. So that could be why we often see repeated scaling and root planings, because we can't manage all that bacteria. So again, we need a way that we can deliver down deep to be able to deliver the medicament to debride the bacteria and also to help moisten tissues and help cleanse the teeth overall. So the majority of your patients would start off wearing trays twice a day, and then you would just simply bump them down to once a day. And that's your protocol. Again, 10 to 15 minutes. So some of our goals with ParaProtect trays is obviously we don't want patients to lose any bone, or if they are a perio patient, they've already lost bone, obviously we don't want them to continue to lose bone. We could potentially avoid multiple rounds of scaling and root planing, be able to avoid surgery, provide patients with better quality of life, wider teeth, fresher breath, more confidence. Like Dr. Rowling was saying, you think about the sweet little old person in a long-term care facility or a nursing home or whatever the case may be. And maybe their quality of life has significantly deteriorated because now, maybe they don't have the dentition that they once had, or maybe now that they're not able to eat, they don't want to enjoy social activities, with their friends. So it's really important that we hold on to their natural dentition. And again, if we're not able to do that, being able to replace that dentition and being able to hold on to it so that we can continue with their quality of life, making maintenance appointments easier and shorter, and just overall improving general health and wellness. So here's your patient candidates, just to recap. Again, perio maintenance patients, gingivitis patients. We could even use this on new perio patients. Most certainly our implant maintenance patients. Implants are absolutely amazing, as we all know, but unfortunately bacteria can very quickly fail an implant, and very few patients are able to keep their implants clean by no fault of their own. So again, I used ParaProtect in my last practice as an insurance policy for their implants. If they got an implant in that practice, they were going into ParaProtect, because again, we were telling them that we want to ensure that they can keep their implant for the length of their life. restorative patients. We talked about bad breath, natural whitening, preventative, and then post orthodontic patients as well. So there really is a huge need for this throughout all corners of your practice. We just need to kind of decide, where is this going to fit best in your practice, and what are going to be your standards of care. How much bleeding points or how many bleeding points are you going to deem acceptable in your own practices? Again, Paraprotect says 10, maybe yours is 15, maybe it's 20. It doesn't really matter to us as long as you have a number. That's what's truly important. And not only that, but you're implementing this into your current periodontal protocols. Because if we don't have standards of care and protocols in place, then we're just kind of willy-nilly recommending these things to patients. So again, it's important that we can recognize the signs of xerostomia and know how to be able to treat it and know what products to be recommending. So I wanted to kind of show you a different, some case studies here, which again, I think are very valid in terms of treating patients overall. This was trays into debridement. This particular patient actually refused scaling and root planing, which can happen for a number of reasons, as you all know. But I think that a lot of patients in my own clinical practice refused multiple rounds of scaling and root planing because they were tired of scaling and root planing. And again, we're not using these trays to replace scaling and root planings or perio maintenances or prophies. We're using these trays to make those services better. And again, I think that we've kind of failed to educate patients and allow them to understand that the majority of scaling and root planing is not about managing the bacteria. It's more so about managing the deposit. So we still need a way that we can manage that bacteria adjunctively and be able to fill in the gaps of treatment. So these are absolutely amazing results in terms of, again, no scaling. This was just trays and a debridement. So this is really what you guys get to look forward to in your periodontal maintenance cases. This is one of our 6-month clinical trials that shows that Paraprotect trays before scaling and root planing and after scaling and root planing is more effective than just scaling and root planing alone in terms of reducing pocket depths and bleeding points at both 2 and 10 weeks. So again, whenever you start your patient off in trays, you see them back for their delivery. Ideally, you're going to see them back again in about 2 to 6 weeks so that you can reevaluate them and let them know how they're doing. Hey, is your mouth feeling cleaner? Is it feeling more moistened? How do you feel about the gel? Are the trays still fitting okay? This is a really great time for you to build rapport, but also be able to tell that patient, hey, when you first started, you had 67 bleeding points. Now that you've been on trays for 4 weeks or however long it is that it's been, now you're down to 15. That's huge in terms of being able to tell that patient that they're healing. They're going to know that they're healing because their mouth is going to feel better, but they want to hear it from you as the clinician as well. And again, I know that we very briefly talked about implants. Again, I think it's super important that you implement this into your current implant protocol if you have one. If you don't have one, you need to get one. And just telling patients that, again, hey, implants are great, but they can very quickly fail if we can't manage bacteria and biofilm around implants. That's why we get periimplantitis, perimucositis, and implants fail 10 times faster than natural teeth in patients with chronic perio. So again, just knowing this realization happens all the time. We need a way that we can manage bacteria. This is our treatment guidelines. This is available to you, again, if you were to become a provider. We have specific websites that you guys can visit to be able to access all of this information. It's always at your fingertips. And again, as an account specialist with Paraprotect, as well as a team trainer, we're always here to kind of help guide you through whatever you may need, from big to small, what you think is silly, what's not silly. Again, we're here to help. So we definitely need to be talking about case presentation, educating patients, showing them the intraoral images, going over the radiographs, talking about the probing, and talking about their health histories as well. Again, using it as a roadmap. Something that I learned last year at our annual meeting, which I'm so super excited about. Again, this year, Dr. Rowling is going to be speaking, and we're so over the moon to have her. But PG in the mouth cannot be broken down by the acidity of the stomach, which is why it's directly related to colorectal cancer. So now if you see colorectal cancer on a patient's medical history, I hope that that's a red flag for you to think, maybe I need to look a little bit deeper at this patient's medical history. Maybe I need to look a little bit further into their periodontal assessment. Remind patients it's comfortable, it's non-invasive. We're going to be able to get down deep and fight bacteria, and it's easy to use 1 to 2 times a day, 10 to 15 minutes. Again, they can wear it while they're in the shower or commuting on the way to work. Maintenance trays are going to last a very long time, 5 to 7 years. And again, they're going to get those benefits of wider teeth and fresher breath as a result. Like I mentioned earlier, we do accept 3D scans. We also accept traditional impressions, models. So however you guys want to send these cases into us, we're more than happy to accept them. Again, if you're scanning or you're impressing, we do require 4 millimeters of tissue above the gingival margin. I've heard that we're really picky, but it's just because we want to turn around a really great product to you guys and know that the trays are fitting really well to be able to do what they're supposed to be doing. This is your home care kit. So this is a case that's going to come with your ParaProtect trays from the lab. And again, this is a whole system. So not only do you have your home care kit, but you're also going to have your travel case, your tube squeeze, your 3 tubes of perio gel. This really sets them up to succeed, guys, for the first few weeks to months of treatment. So again, depending on how often your patients are going to be wearing trays. We just simply apply the gel in the tray. It goes along the central groove. It's a thin ribbon of gel is what I used to tell patients. And again, they're just wearing it for 10 to 15 minutes and then brushing the trays out with water and a toothbrush. We also have 2 CDT billable codes for the trays. We have a maxillary code and a mandibular code. Again, these are laboratory process trays. They do have to go to a certified ParaProtect lab because of the FDA clearance. And especially it's important to know as we're gearing towards the end of the year, be asking patients if they have HSAs, if they have FSAs, they can use these types of accounts to help pay for ParaProtect trays. Again, because some of these patients are either going to use them or they're going to lose them, quite literally. So the benefits to your practice is obviously we're going to help improve our results. We're going to help patients accept treatment, encourage retention, make the hygienist job so much easier. We don't have to wait for the perfect patient either. It's not a boards patient. We can implement this right now with our existing patients just by identifying who needs help, who's still bleeding and scaling or after scaling and root planing, who's still bleeding in a prophy, who's got dry mouth, who's got diabetes, all of these things. And again, little to no overhead or extra cost. Your lab fee is very low in comparison to what you could be producing with the help of ParaProtect. And we also offer incentives and different things for the team, half off of your own trays for the team, free gel if you guys hit in a certain tray amount. So again, there's a lot of things available to you, resources as well as your account specialist, again, such as me, educational videos, stuff for your website, on hold phone messaging, free training for your team. You guys just need to let us know when you bring on new team members, and we're more than happy to help. And last but not least, I hope that you can join us in Scottsdale, Arizona. I am so excited. I've never been before, and I've heard it's absolutely beautiful. The 3rd and the 4th, 2 full days of learning. 13.5 CEs available to you. And again, Dr. Rowling is going to be speaking for us, and we're so super excited. So I hope that you can make it either on the live stream or in person.
Thank you, Megan, so much. And we're excited to have you all here in Scottsdale in a month.
Yes.
And the weather is going to be beautiful. It's the best month to be in Scottsdale, I have to say. So I don't advise August, but definitely November. I want to thank everyone for being here. Are there any questions for Megan? Please go ahead and type them in the chat area. And again, you have her presentation in the course folder and a way to reach out to her. There's also a blue banner at the top of the screen. If you tap on that banner, you can bookmark the URL and take that information back to your practices as well, or review it tomorrow when you're a little bit more awake. We know it's a little bit late on the East Coast, so we appreciate everybody being here. Let me double check and see any questions here for you, Megan. What's the range of fee for patients? This is Angela.
Yeah, this is a great question. The national average for trays is usually between $600 and $800. And of course, this can vary on your location. Historically, offices in California, you're charging a little bit more. But the beauty of this is that, again, you truly get to decide what you want to charge. So, making it affordable for those who, are maybe delivering care to long-term care facilities, or if you're looking for more of a revenue source, it can really go one of two ways.
Terrific. Well, thank you so much for being here, Megan, and for your presentation, and of course for the support of PerioProtect. And I look forward to seeing you all here in a month for our presentation. And again, I encourage everybody to reach out to PerioProtect, or you can tap on the banner at the top of the screen and bookmark that URL for later. Thanks so much, everyone, for being here. I'm going to go ahead and close out now, and you'll be redirected to complete the quiz for CE credit. You'll also be sent an email here within just a minute with the quiz link as well. Good night, everybody. Thank you so much, and we look forward to having you join us again. Thanks, Megan.
Thank you.